Good afternoon. My name is Jarrett Casanidi, Capacity Building Coordinator for the AIDS Education and Training Center's National Center for HIV Care in Minority Communities. Before we begin today's clinical webinar number 5, Introduction to Antiretrovirals, Part 2 of 3, I would like to introduce you to today's presenter, Dr. Mirta Soto-Rosario. Dr. Soto-Rosario is a doctorally prepared pharmacist who serves as a clinical consultant for the AETC NCHCMC. She has no relevant financial relationships with commercial interests, nor discusses unlabeled or unapproved uses of drugs or devices during the presentation. Dr. Soto-Rosario?
Good afternoon. Thank you, Jared. I am happy to be with you again to continue our discussion of the antiretrovirals. As we discussed during the beginning of the last webinar, throughout these 3 webinars, we will have discussed the goals of antiretroviral therapy, which were addressed during the first webinar, and for today we will continue describing the antiretroviral drug classes and their pertinent clinical considerations. During our discussion this afternoon, we will be talking about the following ARV drug classes: the NNRTIs, or the non-nucleoside reverse transcriptase inhibitors, the Integrase strand transfer inhibitor, or Integrase inhibitor, and the Fuzeon inhibitor. The highlighted medications are those we will be discussing in greater detail this afternoon. First, we will address the NNRTIs, or the non-nucleoside reverse transcriptase inhibitors. As with the drug class we discussed during the last webinar, the NNRTIs work on the reverse transcription process of viral replication. As you may recall, the viral reverse transcriptase is the enzyme that converts single-stranded viral RNA into double-stranded DNA. The non-nucleoside reverse transcriptase inhibitors work by directly binding the enzyme, reverse transcriptase, which then interrupts DNA polymerization. All medications in this drug class undergo hepatic metabolism and fortunately do not require any dose adjustments in patients with renal impairment. As you recall in our previous discussion, the NRTIs, a lot of those medications require renal dose adjustments, and that's why we had all those tables with the varying doses of medications depending on a patient's creatinine clearance. Conversely, with the NNRTIs, there are many cytochrome P450-mediated drug interactions. This drug class also has a low genetic barrier to resistance, which means that a single mutation confers cross-resistance to all the first-generation NNRTIs. And the first-generation NNRTIs include Efavirenz, Viramune, and Nevirapine. It's important to know that there's only one agent in the second-generation NNRTIs, and we will discuss that in the next slide. In addition, it's important to note that although there's a significant number of patients that are newly diagnosed that you may think can take any medication in any of the drug classes, a lot of these patients have acquired the NNRTI-resistant virus. During our last webinar, the need for baseline genotype resistance testing was emphasized, and we also discussed that 6 to 16% of patients may have baseline resistance. Of these patients, NNRTI resistance is the most common. In the first generation NNRTIs, these medications have been proven to be very useful in NNRTI-naive patients. However, a single mutation, the K103N, can confer resistance to the entire class. While these medications have a low genetic barrier to resistance, they did work effectively in patients who were wild type or did not have any resistance. However, because one mutation would confer resistance to the entire class, this led to the development of NNRTIs with a higher genetic barrier to resistance and better potency against viruses with NNRTI resistance mutations. The so-called second-generation NNRTIs came about. In vitro, Etravirine, the only currently available second-generation NNRTI, has equipotent activity against wild-type HIV and strains that express multiple mutations that would otherwise confer resistance to the first generation NNRTIs. As a class effect, all NNRTIs are known to cause rash, though how commonly this occurs depends on the agent. Overall, Nevirapine is most commonly associated with rash, 15% versus 6% compared with placebo, followed by Rilpivirine and then Efavirenz. Grade 3 or 4 rash has been reported in Intelence, and rates of discontinuation in published trials averages about 2% of all patients related to the rash. In addition, hepatotoxicity can occur with any of the agents in this class. The medications within the NNRTI drug class are Rilpivirine, Efavirenz, Nevirapine, Rilpivirine, and the second generation NNRTI is the Etravirine, also called Intelence. Current fixed-dose combinations available with an NNRTI are a tripla, which contains Efavirenz and 2 NRTIs, Antiretrovirals, which we discussed during the last webinar, also called FTC, and tenofovir, also called TDF. The other combination product is brand name Complera, which was recently approved, and it contains the same NRTI backbone and the NNRTI Rilpivirine. Rilpivirine, also called DLV, brand name Rescriptor, is dosed 400 milligrams 3 times daily. It has the least clinical data supporting its use and appears to have the least antiviral activity. Therefore, it is not recommended as part of an initial regimen. In addition, its inconvenient dosing frequency is another reason for its lack of use. We will not discuss additional details pertaining to this medication as it is rarely used. Efavirenz, also called ESB, brand name Sustiva, is another NNRTI within this drug class. The adult dose is 600 milligrams daily at bedtime. It is important to remember that patients should take this medication on an empty stomach. If this medication upsets a patient's stomach, he or she can take Efavirenz with a light snack, such as dry toast or a few crackers. Patients need to be counseled to avoid taking Efavirenz with a high-fat meal, as this increases the likelihood that they will experience adverse effects. Though no formal dose adjustments are made, it is recommended to be used cautiously in patients with hepatic impairment. It is important to be aware that the central nervous system side effects are generally mild to moderate, and as providers, we must assure patients that they usually resolve within 2 to 4 weeks. Because of the CNS effects that Efavirenz can cause, this medication should be used cautiously in patients with a history of psychiatric illness. This is not to say that a well-managed patient with stable, treated psychiatric condition cannot be given Efavirenz, but rather, clinicians should be aware of potential side effects and monitor their patients accordingly. An interesting phenomenon that can occur in patients taking Efavirenz is that some drug screening assays have reported false positives for cannabinoids and benzodiazepines while taking Efavirenz. A very important clinical consideration to keep in mind when initiating Efavirenz is its risk of birth defects if given during pregnancy, especially within the first trimester. It is a pregnancy Category D medication, and there have been several reports of neural tube defects in infants whose mother took this medication within the first 3 months of pregnancy. It has also been shown to be teratogenic in non-human primates, and because of these potential risks, it is generally not recommended in women of childbearing age who are planning to become pregnant or in those using birth control incorrectly or inconsistently. Because the majority of pregnancies are not detected during this precarious period, I would caution you against using this medication in women of childbearing age in whom you cannot guarantee that they will not unexpectedly become pregnant. Efavirenz is metabolized by cytochrome P2B6 and 3A4, and it is an inducer of 3A4 and also an inhibitor of 3A4, although it is more of an inducer than an inhibitor. If you're familiar with pharmacokinetics, you know that the vast majority of medications are metabolized by the CYP3A4 pathway, which means that there are a multitude of potential drug interactions with efavirenz. These are only some of the drug interactions between efavirenz and other medications, and when in doubt, chances are there are some drug interactions to consider when a patient is taking medications for other comorbidities. The following medications that I have listed here are those that should not be used at any dose with efavirenz and are contraindicated. For a more comprehensive list of drug interactions with efavirenz, I would like to refer you to Table 15B of the DHHS guidelines. Nevirapine, or NVP, brand name Viramune, is another NNRTI, and it has a unique dosing schedule. During the initial lead-in period, 200 milligrams is given daily for 14 days, then followed by 200 milligrams twice daily, or 400 milligrams of the Viramune XR formulation. If the drug is discontinued at any given time for more than 7 days, the lead-in period should be repeated. This lead-in period will help to decrease the severity of the rash and attenuate it if needed. The lead-in period can actually be continued for up to 28 days until the rash resolves in the absence of constitutional symptoms. There is limited data to support its use in hemodialysis patients, and it is contraindicated in patients with moderate to severe hepatic impairment. Nevirapine has a black box warning for fatal and non-fatal hepatotoxicity and fatal and non-fatal skin reactions. Symptomatic, sometimes very serious and life-threatening hepatic events have occurred in patients taking nevirapine. The risk of these events is greatest in females with CD4s above 250 and men with CD4s above 400. It is imperative to know that nevirapine should not be given to these patients unless the benefits would clearly outweigh the risk. Given the numerous alternative agents that are currently available, another agent should be utilized in these patients. The most updated guidelines have moved nevirapine-containing regimens from alternative to acceptable. And at the end of the presentation, I will point you to the reference where you can review the most updated guidelines, which were released on October 14th, so just this past week. Unlike efavirenz, nevirapine is a pregnancy Category B medication. Like efavirenz, nevirapine is also metabolized by the cytochrome P450 system and is a CYP3A4 and 2B6 inducer. And this basically means that nevirapine increases the levels of these enzymes that metabolize other medications, thus decreasing the levels of the medications in the body. These are some of the medications commonly seen in practice that interact with nevirapine. Because a significant number of medications are metabolized by CYP3A4, when in doubt, the medication probably interacts. And for a more complete list of medications that may interact with nevirapine, I would encourage you to review Table 15B of the DHHS guidelines. The medications that are contraindicated with nevirapine and should not be used at any dose with nevirapine include these referenced below. Etravirine is the second-generation NNRTI we have discussed briefly and is only indicated for treatment-experienced patients. It is currently available in 100 and 200 milligram tablets. However, the dose remains the same of 200 milligrams twice daily. It is important to be aware that this medication comes in two strengths to avoid confusion in patients taking either too much or too little of the medication if the strength prescribed is changed at any point in time. This medication must be taken with a meal, and the unique feature that this medication has is that it can be dissolved in water, and the tasteless slurry can facilitate patient adherence. Some patients don't want to have to swallow so many pills, so this is a good advantage for these patients, a good option. An important counseling point when advising patients to dissolve the tablets in water is to ensure that they rinse the cup several times and drink the remaining slurry to ensure that the entire amount of the medication is consumed to get the full dose. As far as drug interactions are concerned with etravirine, etravirine induces 3A4 and inhibits 2C9 and 2C19. In practice, this means that this drug decreases the level of some medications and increases the levels of others. Some clinically significant drug interactions with etravirine include carbamazepine and other antiepileptics, fluconazole, sildenafil, brand name that you may be familiar with, Viagra, and clopidogrel, which is important, brand name Plavix. In addition, etravirine is a P-glycoprotein inhibitor, which can potentially lead to drug interactions with other medications like digoxin, cyclosporin, and morphine, which are all PGP substrates. The medications that are contraindicated with etravirine and should thus not be administered at any dose are listed here for your reference. And now we come to the final NNRTI, Rilpivirine, brand name Edurante. This is a new drug in the class approved in May of this year. This is a first-generation NNRTI like Efavirenz and Nevirapine. The recommended dose is 25 milligrams daily. And unlike Efavirenz that must be taken on an empty stomach, Rilpivirine must be taken with a meal. An important counseling point is that patients must understand that this medication is not to be taken on an empty stomach or with a snack. When the initial studies were conducted, it was found that 500 calories were necessary for optimal absorption and efficacy. Subsequent studies when Complera, which is the combination product that includes Rilpivirine and 2 NRTIs, it was then found that 400 calories were sufficient. Nonetheless, it is important to make the distinction between take with food versus with a meal, and with a meal involves mechanical chewing of food. Though there are no dose adjustments recommended, Rilpivirine should not be used in patients with severe renal impairment. And no dosage recommendations are available for patients with the Child-Pugh Class C, according to the most recent guidelines. Like Nevirapine, Rilpivirine is a pregnancy Category B medication. It is an important clinical consideration is that when this medication was being studied and seeking FDA approval, it was compared in a non-inferiority trial to Efavirenz. It was shown to be non-inferior to Efavirenz in a certain group of patients, which granted its approval. However, more patients with viral loads greater than 100,000 copies at the start of therapy experienced virologic failure compared to those patients with baseline viral loads less than 100,000. This important information must be considered when you're thinking about starting Rilpivirine, which is currently only indicated in patients who are treatment naive. So if you have a patient who is coming into care with a very high viral load above 100,000, it should not be recommended because you're running the risk of experiencing virologic failure in these patients. This medication is metabolized by CYP3A4 and thus interacts with the anticonvulsants, antimicrobacterials, proton pump inhibitors, which is an interaction we have not yet seen, and St. John's wort, which you have seen in several other of the slides with the NNRTIs. This medication requires an acidic environment for adequate absorption and plasma concentration. In addition, for a complete list of known drug interactions for this medication, I encourage you to review the package insert for Edurante, and the most updated guidelines and Table 15B of the DHHS guidelines will also include more information. As I mentioned briefly, the increased gastric pH may decrease the plasma concentrations of Rilpivirine. So that basically means if you have a patient that's taking antacids, chances are they're taking this medication as an over-the-counter without prescription. So it's important to be counseling all patients in the event that they think that this seemingly innocuous product would not have effects with their medication. They should be counseled to take the antacid at least 2 hours before or 4 hours after rilpivirine. The H2 receptor antagonists, such as ranitidine or famotidine, should be taken 12 hours before or 4 hours after rilpivirine. And if you have any patients that have been taking proton pump inhibitors, such as Prevacid, which is now available without a prescription, or Prilosec, it's important to tell patients that they cannot take those if they're taking rilpivirine. While limited data is available on the pharmacodynamic interactions between rilpivirine and drugs that prolong the QTc interval, it is important to use rilpivirine with caution in medications that can cause torsades de pointes, such as antiarrhythmic drugs like procainamide, flecainide, sotalol, and amiodarone. Medications that should not be co-administered and are thus contraindicated are listed here for your reference. And it is important to note that for the glucocorticoid dexamethasone taken systemically, it is specifically described that it's only contraindicated in more than one dose. So if you have a patient taking a one-time dose of dexamethasone before a procedure, that is okay. But more than one dose of dexamethasone would be contraindicated. It is also important to consider that while the recommended daily dose is 25 milligrams daily, the doses used in pharmacokinetic studies range between 75 and 150 milligrams daily. And now we will pause briefly for a question, and I request that each of you respond via the chat feature located on the right-hand side of your web browser. Which of the following medications interact with the NNRTI? Okay, I see that one of the participants has selected B, St. John's wort, and that is correct. That is an herbal supplement that does interact with the NNRTIs, and actually the anticonvulsants also interact with the NNRTIs as well as rifampin. So the correct answer is D, all of the above. As we have mentioned briefly during our discussion of the individual agents, each of these agents within the drug class has unique side effects to be aware of, as it is important to counsel patients on the expected side effects to minimize the risk of abrupt discontinuation and to allow patients to be adequately informed of possible side effects they may encounter while maximizing adherence. Efavirenz neuropsychiatric effects can include abnormal dreams, which some patients have actually even reported that they may enjoy, confusion, abnormal thinking, impaired concentration, dizziness, somnolence, agitation, hallucinations, and even euphoria. Up to 50% of patients can experience these side effects, but after 2 to 4 weeks, they usually subside. As discussed previously, this medication is associated with teratogenic effects in non-human primates, and there are reported cases of neural tube defects in humans after exposure to efavirenz within the first trimester. Nevirapine has the highest rate of rash within this class, and it also can cause the hepatotoxicity that we mentioned before. And the risk is higher in patients with higher CD4 counts at the time that they start therapy and in women. It's important to note that if you have a patient that you start nevirapine on who qualifies because their CD4 counts are low, it is expected that their CD4 is going to go and increase while they're on therapy as they become better controlled. This is not to say that you should be discontinuing this medication. You should not be discontinuing the medication as the CD4 count goes up with therapy. The risk of the hepatotoxicity that we're talking about is when they're starting therapy. Rilpivirine has a better side effect profile, although this drug was just approved. So we will not know all the potential side effects until we have more clinical experience with it. And the text here in blue includes the updated information that has been summarized from the DHHS guidelines. So depression was previously, we were aware of that, but it also can cause insomnia, rash, and headache. Etravirine is also associated with rash and can even cause Stevens-Johnson syndrome. It can also cause a hypersensitivity reaction and some nausea. And now we interrupt our discussion for a brief question. Please answer using the chat function on the right-hand side of the browser. Which of the following medications is not affected by co-administration with antacids? Okay, good. The correct answer is tenofovir. Didanosine and rilpivirine have specific requirements with regards to needing an acidic gastric pH for optimal efficacy. So tenofovir is the only one that you would not have to worry about. We're now shifting gears and we'll discuss the Integrase strand transfer inhibitor. This drug class targets the integration step in which the viral DNA is integrated into the host DNA. By preventing integration of the HIV DNA into the host cell genome, integrase inhibitors prevent the formation of the provirus. These proviruses are required to direct the production of the new virions. Therefore, the integrase inhibitors halt the HIV production. There is only currently one drug approved within this class, Raltegravir, which undergoes hepatic metabolism via the UGT1A1-mediated glucuronidation. Raltegravir, brand name Isentress, is dosed 400 milligrams twice daily and can be taken without regards to food. It does not require dose adjustments in patients with mild to moderate hepatic impairment and has not been studied in patients with severe hepatic impairment. That being said, Raltegravir may be dialysable. Therefore, patients should be taking the Raltegravir doses after a dialysis session as a precaution. However, there are no dose adjustments needed for those with renal impairment. Like the NNRTIs, this medication has a low genetic barrier to resistance, and in terms of its side effect profile, it is a fairly well-tolerated medication. Rifampin, a strong inducer of UGT1A1, reduces plasma concentrations of Raltegravir. In patients who are going to be co-administered with rifampin, the Raltegravir dose should be increased to 800 milligrams twice daily during this time period when there's co-administration. The impact of other inducers of drug metabolizing enzymes on UGT1A1, such as phenytoin and phenobarbital, is currently unknown. The most common adverse reactions of moderate to severe intensity compared to the placebo included insomnia and headache in clinical trials. CPK elevations were observed, and myopathy and rhabdomyolysis have been reported, and therefore Raltegravir should be used in caution with patients taking other medications that may increase the risk of these myopathies. Now that we have discussed 3 different drug classes in total, let's answer the following question. Please select which medication can be taken without regards to meals. And there are several correct answers here. Okay, I see somebody's answered A, Abacavir, and that is correct. That is one of the answers. I see somebody else answered Efavirenz, and actually remember that Efavirenz should not be taken with a high-fat meal because it increases your risk of adverse effects. So the correct answers are A, Abacavir, D, Raltegravir, which we just discussed, and E, Nevirapine. These can be taken without regards to meals. And now we will discuss the final drug class of this webinar, the fusion inhibitors. Medications within this drug class target the fusion process by which the viral and host cell membranes fuse. The fusion inhibitor interferes with the entry of HIV-1 into cells by inhibiting the fusion of the viral and cellular membranes. There is only one drug within this class that is currently available. Enfuvirtide, brand name Fuzeon, also called T20, binds at the GP41 subunit of the viral envelope glycoprotein and prevents the conformational changes required for the fusion of viral and cellular membranes. This is the only medication currently available that is not administered orally. It is currently only indicated for treatment-experienced patients, and because of its poor tolerability, is generally safe for future regimen combinations in salvage regimens. The dose of the medication is 90 milligrams administered subcutaneously twice daily, and each vial contains active drug that has to be reconstituted with sterile water that is provided in the packaging. The reconstituted solution should be refrigerated and used within 24 hours. So if you have patients that would like to prepare a batch of syringes of their T20 medication, it is important to notify them that the reconstituted solution is only stable for 24 hours, so they cannot prepare the solution too far in advance. And this medication is expected to undergo catabolism to its constituent amino acids with subsequent recycling of the amino acids into the body pool. Therefore, there are no significant drug interactions. The injection site reactions are the most common adverse effects seen with T20 and can occur in almost 100% of patients. These can include pain, erythema, induration, nodules and cysts at the injection site, pruritus, and ecchymosis. In addition, an increased risk of bacterial pneumonia has been reported. It was observed in the patients receiving Fuzeon in phase 3 clinical trials. It is unclear if the increased incidence of the bacterial pneumonia was related to the medication use. However, because of this finding, patients with HIV infection should be monitored for signs and symptoms of pneumonia, especially if they have underlying conditions that may predispose them while taking this medication. A hypersensitivity reaction has been reported with this medication, and the patients may present with rash, fever, nausea, vomiting, chills, rigors, and elevated serum transaminases and hypotension. Rechallenge is not recommended for patients that have experienced a hypersensitivity reaction to Fuzeon. This concludes part 2 of the webinar on antiretroviral review. The third webinar will also cover the protease inhibitors, the CCR5 antagonists, and combinations to avoid. I would urge you to please complete the evaluation of this presentation, as this will help me tailor this presentation to suit your needs. I value your input and feedback and encourage you to complete the evaluation to ensure that you get the most out of these webinars. I would like to point out that this is the reference that I've mentioned in the presentation that is the most updated guidelines that were published just last week. The link is here for your review, and I encourage you to check it at your earliest convenience. I thank you for your time, and I would be happy to answer any questions you have at this moment.
Thank you very much, Dr. Soto-Rosario. At this time, we are unmuting all phone lines for your questions. If you would like to ask a question, please click the Raise Hand button so we may call on you, or use the chat feature to type your questions. And all phone lines are now unmuted. And I am not seeing any questions coming in. There will be a recording of the presentation today on the Building the Foundation page in the Virtual Learning Lab, so you can always go there and refer to it. So thank you once again, Dr. Soto-Rosario, and thank you all for participating in today's webinar. When the webinar is over, as Dr. Soto-Rosario mentioned, an evaluation will appear in your browser window, and please do take a few minutes to complete the evaluation, as it will help us better prepare for future webinars. You can reach Dr. Soto-Rosario or any member of the AETC and CHCMC staff by emailing us at clinical@nchcmc.org. The next clinical webinar is scheduled for Wednesday, November 2nd. Thank you very much, and enjoy the rest of your day.